You're listening to The Scoop on Ultrasound, where the world of ultrasound imaging comes alive through dynamic conversations. This episode is brought to you by EDM Medical Solutions. It's an all-new season of The Scoop on Ultrasound. In our first episode, we discuss the key issue of endometriosis and emerging imaging trends with Alison Deslandes, president of the Australasian Society for Ultrasound in Medicine and research PhD candidate at the Robinson Research Institute.
Quality supplies make a difference. At EDM, our mission is to help you enhance patient care. For over 30 years, we have been a leading supplier of medical imaging products and accessories. It all started with one product, Crystal Ultrasound Gel. And now our catalog includes over 300 products designed to support your practice. From probe covers to needle guides, EDM Medical Solutions is the partner of choice for over 2,000 healthcare facilities in the U.S. Learn about our range of ultrasound solutions on our website by visiting us.edm-imaging.com.
Today we'll be discussing an important topic in women's health, endometriosis. Endometriosis is a condition that affects 5 to 10% of women of reproductive age globally. And in the US, actually, researchers estimate that more than 6.5 million women have endometriosis. And it represents a significant challenge for patients experiencing the symptoms, many times which involve severe pain. So today we'll be tackling the question of how we can best leverage imaging to detect and diagnose this condition. Our guest today has a great deal of knowledge to share with us. Alison Deslandes is the president of the Australasian Society for Ultrasound in Medicine. She has over 15 years of experience in sonography, and in addition to leading the ASUM, she is also a research PhD candidate at the Robinson Research Institute at the University of Adelaide. Her research there centers on creating AI tools to enhance the diagnosis of endometriosis with ultrasound and MRI. Alison joins us from Australia with quite the time difference, so thank you for being here today.
Thank you for having me. It's very exciting to talk about endometriosis any time of the day or night.
Absolutely. So, like I alluded to, endometriosis is a difficult condition. It's also difficult to detect and diagnose, right? At times, the symptoms can easily seem like something else. And so for the healthcare team, that presents a challenge. So imaging can give us an enhanced ability to catch these cases and work to give patients proper treatment. At least that's the idea. I wanted to note how very recently the Society of Radiologists in Ultrasound, the SRU, issued a new consensus statement that provided recommendations for enhancing routine pelvic ultrasound scans by using additional maneuvers. The end goal being to improve the diagnosis for deep endometriosis, because the ultrasound scans are typically done when there's pelvic pain, but sometimes the maneuvers or the way that the scan is being done is not really done to detect endometriosis. So there's an effort being made, not just by the SRU, but by the medical community as a whole. So could you begin by explaining the critical role that imaging plays in diagnosis and treatment of this condition?
Yeah. So I think that endometriosis typically can present with quite a spectrum of symptoms, and you're correct. Sometimes they're very hard to pinpoint to exactly what it can be. It can mimic a lot of other conditions. But the two that typically come through quite strongly are pain, so chronic pelvic pain, pain with periods, pain with sex, that sort of thing. And then infertility is the other one that presents quite strongly. In both of those cases, typically ultrasound would be used to investigate those, whether it be to rule out causes of other things, whether it be to try and pinpoint a cause of those. So historically, we've always seen a lot of these people coming through ultrasound departments because we are investigating them for their problems. So it just makes a lot of sense that you would use that ultrasound, which is often one of the first investigations of those problems, to try and pinpoint endometriosis, which is often the cause of that problem. when it comes to using an ultrasound to investigate endometriosis, there's sort of two pathways, I suppose, that it can be used for. One is the diagnosis of endometriosis. So basically people present with those symptoms. We want to know what's causing those symptoms, and the ultrasound can be performed in such a way that we can try and detect endometriosis lesions. The other pathway is a surgical planning pathway, and imaging has a really vital role in that, because historically we've used laparoscopic surgery to diagnose endometriosis. Now, that's not an ideal way to diagnose something. It's quite invasive, it's painful, it's expensive, it carries risks with it. But it also allows a good view of the peritoneal surfaces, which is really helpful for detecting superficial disease. And it also allows it to be excised at the same time. So people can sort of have a one-stop shop sometimes. The problem is when you've got a lot of deep endometriosis and very severe disease, it can cause quite a lot of adhesions in the pelvis. You end up with a situation where the organs are stuck to each other, they're stuck to the side wall. The view then becomes very obscured, so the surgeons can't actually see properly past all of those adhesions what's happening, but it also becomes very complicated surgery and more risky surgery. So you actually need teams that are very advanced surgical teams, very confident with pelvic anatomy, and have a lot of experience in these surgical techniques to be able to safely remove that disease. So ultrasound initially was sort of investigated as really a surgical planning tool to see if we could try and facilitate better planning of surgery, so we could see down past those adhesions, which you can do very well with an ultrasound. So the surgical teams could make sure that they were properly informed, they could triage to a really advanced team if needed, they could get bowel surgeons in if there's bowel disease involved and that sort of thing. From that evolution, though, we've sort of circled back to this idea that we can actually diagnose quite well. And I think the algorithm for treatment over the years has started to change as well, where we're moving away from surgical management as the sort of only option to having more holistic care, where we incorporate medical therapies, allied health like physiotherapy, complementary therapies, acupuncture, those sorts of things. And give people a choice of what they want. So really, when we sort of circle back to that diagnosis piece, we get those people that first present and we can use the ultrasound to diagnose. Now, they are slightly different, and I think it's good that you mentioned the SIU consensus, because in 2016 we had the IDEA consensus, which is the International Deep Endometriosis Analysis Group consensus, and that was the first sort of consensus that came out that gave a bit of a guide and a pathway to how we should perform and document an endometriosis scan, and that's very comprehensive, and it's excellent for surgical planning, and it is excellent for research because it gives us a very clear pathway of how we should be reporting things. But one of the things we are starting to find, or I'm starting to find in a lot of my teaching, is that the more general practitioners, so people that work in a radiology setting and do a bit of scanning of everything, do find the upskilling to do that very challenging. I think the SIU consensus sort of has proposed a slightly less involved technique. I think it has a lot of strengths to it, and I really sort of agree with the idea that we should be trying to do something that's going to be more accessible. It hasn't been tested yet, unfortunately, so we don't know what level of endo it will diagnose, and I think that there's maybe a few key points that they may have left out of that, but we'll see how it goes. But I think that it's really important that we do think about trying to assess the structures of the posterior compartment with ultrasound to get that diagnosis of endometriosis for people.
Exactly. So you touched on a point that I wanted to expand on, and that's about the effectiveness of ultrasound. You mentioned how the laparoscopic method is expensive, it's painful. So could you just explain a little more on what makes, though, the ultrasound so effective, and how does it compare to other imaging techniques? Because we'll get into MRI versus ultrasound after, but in general, in terms of accessibility and cost effectiveness, what sort of impact do you feel it could have?
Oh, look, I think if we could get to a point where we have most people trained to perform an ultrasound that can detect endometriosis, so that's scanning beyond just the uterus and ovaries and looking into particularly the posterior compartment, we would certainly expand diagnosis immensely. I think there's radiology practices and ultrasound machines all over the place. It's in most parts of the world, it's quite easy to get into have a pelvic ultrasound. And although there may be a cost involved, they often are covered by government subsidy schemes or insurance schemes, and often the costs are not that high. It's, you know, in the order of hundreds of dollars if you're paying the full fee. Surgeries often, by contrast, are in the orders of thousands of dollars if you're having to pay full fees, and insurance coverage and things can be a little bit different. So I think that ultrasound really could expand diagnosis quite immensely. And we're sort of finding that in my practice, where we are all now quite upskilled to perform scans for endometriosis, I mean, we can within minutes detect disease and give people that knowledge that that it's there. It is important to note that there are limitations with ultrasound, and most of the work that's been published to date really focuses on diagnosing ovarian endometriomas and deep endometriosis, which are two subtypes of the disease. There is a third subtype of the disease, which is superficial endometriosis or peritoneal endometriosis, and that's where the lesions are very small. They're sort of millimetre type deposits on the surface of the organs and the surface of the peritoneum. They almost look like pimples on the inside. Those, because of their very small size, can be very difficult to detect. There is some research work happening around trying to use ultrasound to detect those lesions, but that's very much still in a sort of research context. It's got a very small amount of sort of clinical readiness, I suppose, at this stage.
Right.
But the future will go there. But it means at this stage that we're sort of limited to only those two subtypes, the ovarian and the deep disease, that we can diagnose. So it's very important that consumers know that if they've had an ultrasound that is normal, it actually doesn't exclude their endometriosis. But there certainly are a group that we're starting to diagnose quite confidently with imaging. In terms of how the ultrasound compares to other imaging techniques, as you asked, the other imaging modality that's quite useful for diagnosing endometriosis is MRI, and that it has similar limitations. It works in a slightly different way, but very good for ovarian endometriomas, very good for deep endometriosis, and very good as a surgical planning tool. The T1 fat saturation sequences can show up blood products extremely well. So sometimes we see some of the very small peritoneal deposits with that if they've got blood products in them, but not all will. But I think the sort of limitations are the same in terms of MRI. With the spectrum we can diagnose, so that superficial disease is very difficult on MRI as well.
Right.
The other issue with MRI is that it is more expensive and it's not as available. And we also have the same skill and training issues. So there is not that many radiologists around that have a lot of expertise and experience in diagnosing endometriosis on MRI. So so it's about, again, you know, expanding that access so more and more people can access through MRI as well. Here in Australia, where I am, MRI is also not, our healthcare is mostly government subsidised. So you can have as many pelvic ultrasounds as you want in your life, and the government will pay for those without too many questions, so long as the doctor refers you. MRI you only get to have once every 2 years, and it has to be referred by a gynecologist. So, and it's a far more expensive out-of-pocket cost. So there's a lot more funding issues on MRI for people. Not everyone wants to have a transvaginal ultrasound, but not everyone also wants to have an MRI. So I think it's good that people have options, but lots of people find them claustrophobic and things like that. I think MRI mostly is a really complementary technique to ultrasound. So people will always come for an ultrasound first if they have a gynecological problem. And then MRI can be really helpful to complement the ultrasound. Because it's got a larger field of view, it'll see things further up the bowel than a transvaginal ultrasound will. It can sometimes be very difficult to assess the pelvis if there's things like a large fibroid which blocks view. The MRI can be really helpful in getting that slightly wider field of view. And there will be cases where an ultrasound is a bit equivocal and we're just not sure. And I think sometimes then that MRI can sometimes provide that surety as well.
Okay, so that I was going to ask about that. What would you say then are the key factors influencing the decision between both? Is it really just a matter of cost then, or are there significant technical differences? Or from what you said, it sounds like they're not that different in what they can contribute. Is MRI kind of like a backup?
Yeah, so I think, I mean, as I said, it's that ultrasound's always that first line tool because it's cheaper and more accessible. And it is quicker and easier in a lot of cases than performing an MRI. So it sort of makes logical sense. I think from the work that we're doing in my research group, we've got a large data cohort now of people that have had ultrasounds, MRIs, and then surgery. So it's a lovely data set where we can start to see what the patterns are. And we haven't done a deep analysis on it yet, but from looking at the surface, the ultrasound, I think, we're certainly seeing some of the smaller lesions than MRI is, even though they can sometimes see some of those blood products really nicely. And so that's a big plus. And I think the dynamic nature of ultrasound. So one of the things we'll do is we'll use techniques where we push the uterus away from the bowel and see how it moves. They're very easy to do and quite accurate on ultrasound. You can do some dynamic scanning on MRI, but it's not as easy and it's not as accurate. So ultrasound has some real pluses in that sense. The other thing that ultrasound does is it allows you to get feedback from patients. So you can sometimes push on a nodule and they'll say, oh, that's it, that's that pain I experience. And it's a really helpful kind of biofeedback thing that you can give to a patient to say, well, that's your problem. That's what's causing your pain.
That's a good point.
Whereas you don't get that same feedback with MRI. I think, as I said, they certainly do complement each other, though. And as I said, there'll be that group of patients that don't want to have a transvaginal ultrasound, because when we're talking about ultrasound, we're talking about transvaginal scanning, and not everyone's going to be comfortable with that. And if people have pelvic pain, sometimes they end up with pelvic floor dysfunction and things like that as well, which then makes inserting something into the vagina quite painful. And so I think for that group, having the option of an MRI is really valuable because it empowers them to make a choice that's better for them. I think, as I said, in some cases, the ultrasound will be difficult because there's, a large fibroid or something that blocks view. And so really finding out what's happening with the MRI and the slightly bigger field of view is helpful. And MRI, obviously, because of that bigger field of view, has the potential to look further up the bowel. So on ultrasound, we're limited to about the level of, we can usually see to the level of the distal sigmoid colon, but seeing beyond that is very difficult. And some people will have disease up there. Some people will have disease on their small bowel. Some people might have it on the right side of their bowel and appendix. MRI can see all of that if the windows are opened up, and you've even potentially got the potential to look up to the diaphragm and things as well. So there's some really helpful uses of MRI in that sense. I think MRI also has a really exquisite view of the myometrium, and I think it's probably better than ultrasound at looking at myometrial patterns, and that can be very helpful for a few reasons. But I think particularly if we're looking at adenomyosis, and particularly in the context of fertility and things like that, sometimes the myometrial detail you can get from an MRI can be really exquisite. But it's very much those sort of specific patient indications that might lead you to want to do an MRI in addition to the ultrasound.
Okay, so both have their pros and cons in the end. There's a degree of clinical judgment on a case-by-case basis that has to be used. There's the accessibility factor, but also the imaging technique itself to try to determine that diagnosis and identify the disease depending on where it might be. Yeah, that's really interesting how both can complement one another. Now, talking more about the techniques, the imaging techniques, could you tell us a little bit, especially for the audience members maybe who, this isn't their specialty, they don't know too much about this, how have these imaging techniques contributed to understanding the incidence, the prevalence, and the trends in endometriosis diagnosis over the years, especially as it relates to the literature?
Yeah, so that's a great question, and I think that's probably one of the things I find most exciting about imaging is that we're really starting to understand the disease in a way we didn't before, and we're actually starting to now be able to do studies where we're looking at the effects of drugs and things, and we can look at what's happening to the lesions on imaging as a response to those therapies. We never were able to give patients that information before because when you have to go in surgically to look at things, typically most people then want their disease cut out of them. They don't want it left there so that we can do another surgery a year down the track and see how the drugs worked. So it's absolutely a huge benefit of imaging. So there's been some really interesting studies that have come out. It's been a few around infertility, and the literature sort of telling us now that, about 20 to 30% of people that present with infertility and have a detailed ultrasound to look for endometriosis will have nodules that are visible on their ultrasound. So that's hugely beneficial for our understanding of endometriosis-related infertility and sort of prevalence of endometriosis in that population. And it's also extremely helpful to then guide therapy, obviously, for those patients as well, because if we can get a diagnosis of what might be contributing to their infertility, we can make sure that we tailor their treatment plan to encompass that. There's been some very interesting work from the UK, from Dave Oljukovic's group, where they have now got they've been doing scans for years. They've got a lovely data set, and they've looked at some of the patterns and trends in that. And one thing that they looked at was just the prevalence of people that presented to the gynecology clinic with endometriosis. And I think they found that 19% of people that presented to their clinic for any reason, just a gynecological complaint, they all had a detailed ultrasound for endometriosis, and 19% of them had endometriosis that was visible on that scan. Wow. So when you think that we know there's a portion that we aren't seeing the endo in still, it's a pretty significant problem. And I think we're starting to question now whether those sort of numbers of about 10% that we sort of talk about are actually correct, or maybe that's a bit of an understatement. They also did another really interesting study with their data set where they rescanned the people that did not opt for surgical management and opted for conservative managements of their endometriosis. And they tracked them over many years and many visits. And they found that in that cohort, about 50% of people that had deep endometriosis, it just stayed the same. It didn't actually change at all. And in about 30% of people, the disease progressed on and got worse and more nodules were visible, or they grew in size. And they found in the remaining 20% or so that their disease actually regressed and got better without any sort of intervention, which is really interesting because we've always thought that endometriosis was this progressive thing and it just keeps getting worse and worse. And you have to have surgery to remove it, or it's just going to get worse and worse and it's going to invade all your organs. Now, that certainly does happen for some people, but we also know that there is a group now where that doesn't happen, and that there is some natural cycle of endometriosis where for some reason in some people it will go away. We don't know why, though, so we do need to keep investigating to find out why that happens. But I think it's imaging that's starting to really give us this insight, which is really interesting. Another really interesting thing that we've really learned from looking at the pattern of imaging is there is a subtype of adenomyosis. So adenomyosis is a condition where the lining of the uterus invades into the muscle of the uterus. And it's always been believed that that occurred because the endometrial lining starts to invaginate out into the muscle, and you sort of get this diffuse process typically. And we've always understood that it can be focal, so there can be areas that get affected and areas that don't. But again, with imaging, we're starting to understand and see a lot more that there is a subtype that affects just the outer myometrium, so the very back section of the uterus, and that this is basically caused by endometrium invading in from the outside. Now, it can occur without endometriosis, so we don't fully understand, again, why this happens, but we do often see it with endometriosis. There's a bit of school of thought that it's almost that same pathogenesis of the endometriosis being outside and then kind of invading back into the uterus and forming this condition called external adenomyosis or focal adenomyosis of the outer myometrium. So again, it's one of those things that, you know, without the power of imaging, we didn't really start to understand that. And again, we still don't have all the answers, but you know, it's just providing these really interesting insights and really starting to give us more understanding of how this disease behaves.
Truly fascinating, honestly, to hear all the different examples you gave. And I mean, it really makes the case for imaging, doesn't it? That now with that technology, we can see so much more. Incredible. And it really is challenging what we think. Just how you said that number 5 to 10%, you know, in a few years or a decade, that number may change when we discover more, right? It's just a matter of time as the studies progress. Now, I know that you and the team at the Robinson Research Institute are doing some really cool things for endometriosis with AI specifically. And AI is a big topic. We've talked about it on this show before as it applies to ultrasound imaging. So looking forward, what are some emerging trends or innovations in endometriosis imaging specifically that you find most promising for improving that diagnostic accuracy and these patient outcomes, especially as it relates to your research? I think the audience would love to hear more about that.
Yeah. So obviously, I mean, like most things, artificial intelligence is being investigated as to how that can assist us. And what we're doing in our group is something a little bit different, where we're trying to combine both the ultrasound and the MRI and sort of merge the imaging to get an enhanced diagnosis from that. And we've had a bit of success. We've got a technique now that's been patented specifically related to Patch of Douglas obliterations, and we're continuing to do more work on rectal disease, and we'll keep going and going and going, and it might never be ending, but it's certainly a really exciting area. And we're really hoping that by having these sort of algorithms that can help essentially read imaging, we can help to expand it greatly, so we're not reliant then on making sure that every radiologist everywhere has a great knowledge of how to detect endometriosis on an MRI. They can use these tools to assist with picking disease, and the same with the ultrasound. And if we can get both modalities and combine them, then we can give an even more accurate picture, hopefully. I think in terms of the non-AI side of things, there's also a lot of helpful work being done. A lot of my work is related to sort of teaching and learning, because obviously with ultrasound, no matter what a computer can do, there's always going to be a really important human element to how we perform scans. So we're sort of trying to use AI in that respect as well to help to assist sonographers when they're scanning to learn techniques more quickly, to understand disease, and get a bit of guidance on how to do things in real time. Because one of the problems is access to people that know what they're doing is very difficult as well. And so making sure that you get that guidance can be very challenging. And one of the things we've certainly noticed is there's no shortage of sonographers that want to do better by their patients and want to learn more, but there certainly is a bit of a shortage of experts to teach them. There's a lot of work, as I said, being done around superficial endometriosis. So in 2020, it was Professor George Condis's group and Dr. Matthew Leonardi, while he was working with him here in Australia, that first published on visualizing superficial endometriosis with ultrasound. And so that was a fairly groundbreaking kind of study, in that it really just showed us for the first time we could do this, and it was something that we believed we couldn't do. And I think since then there's been a few more publications, but I feel like we're on a bit of a precipice with really seeing a lot more in that space as well. And once we sort of really can refine techniques around that, I think we'll start to really expand access, because there'll be a whole lot more disease we can see on ultrasound, which will just be able to give more diagnosis to our patients, which will be great. And again, back to sort of just the first principles of human imaging, I think over the years, although it's been probably 20 years now that we've been seeing publications about diagnosing endometriosis, within that time, people have been refining techniques. And with that refining of techniques, we're now sort of understanding how to better teach people and how to really streamline what sonographers are looking at to make sure that they're most likely going to have success in detecting disease. So things like looking at the uterosacral ligaments, there's a bit of work now that's being published on really finding or using a good technique from the posterior fornix to find the ligament consistently and really assess the area of the ligament, which is where we see a lot of disease. And so once sonographers kind of get empowered to do that, we will be able to detect a heap more disease, which will be really exciting to benefit patients and make sure that they get the care that they need.
Absolutely. It's very, very exciting, to hear all the work that you and your team, and of course other teams, are putting into this, because it's such a key issue, isn't it? Especially for those patients who feel frustrated and feel like they're not being heard, or like no one has the answer. These things can really bring clarity. These new imaging techniques can really bring clarity, I think, to those cases, right? And we can better detect it earlier too. That's such a big thing, isn't it? That sometimes it just goes undetected.
Oh, absolutely. And I think, again, it's that whole sort of spectrum of problems where you've got sometimes symptoms that are not not completely indicative clinically of what the problem is, but they're causing a significant impact for people. So they need a solution, and they want an answer to what's going on. And I find often people sort of try and seek care. They don't really get anywhere. They don't get a lot of answers. You know, they may get treatments that don't completely solve the problem. And so, it's actually really common in my practice that I see people who have suffered for years with problems, and we do the scan and we tell them, well, we can see endometriosis, that's what's causing your problems. And, they'll burst into tears in the scan, and you sort of think, I'm sorry, I didn't mean to, upset you. And they're actually really happy, and that's why they're crying. They actually are just so relieved that they finally have an answer, which I know. Which, it seems very confronting, but actually it's, it's just that, their quality of life has been so affected. And when we can actually start to give them answers, that validation that they receive is so huge. And that really kind of is the first step to then, being able to start on their journey of therapy as well, both in terms of clinically opening up options for them, but really just, I think, within themselves to have that understanding, that clarity of what is happening, and that, they're not just crazy. They're not just somebody that's weak and can't put up with these problems. They're actually somebody that has a medical condition that's causing a huge amount of problems.
Exactly. There's probably nothing worse, right, than feeling something and then not knowing what it is, feeling like pain and not knowing how to address it. And everyone tells you, well, sorry, just go home. There's nothing we could do. So that's really nice to hear, just the impact that can have. I'm sure it's bittersweet, but it's great, to be able to give people, to let them know what their issue is and give them, like you said, that validation. And we could do that now with these techniques. And I'm sure that in a few years, that's just going to continue advancing from all that you said.
Absolutely, yeah. And so I think that, as I go around, do lots of teaching all over the world, really, to try and expand these techniques. And like I said, I've never found a shortage of sonographers that want to learn and want to try and do better. And they're very open to this. And I think that, just that open-mindedness of people to try and understand more about the disease can really benefit patients, even if they're maybe not going to be able to detect disease on ultrasound. At least they can, explain to their patient at the time, like, a negative scan actually doesn't mean that you don't have the disease. Like, it doesn't mean that your pain isn't real. And that in itself is, quite validating to people. And, they can leave feeling like they were sort of listened to and heard, and that, their problems are still serious.
Exactly. Now, one last question. I know you mentioned how there's no shortage of sonographers that want to help. I believe that that's definitely true. So what are some resources that you would recommend for sonographers and even maybe physicians who are using ultrasound in their practice? What are some resources that you would recommend for them to learn more about how they can scan better, or just how they could leverage the tool in a new way, maybe?
Yeah, absolutely. So there's a lot of really great resources all across the internet, which are free. So I highly recommend downloading the Idea Consensus paper and reading that. It's got fantastic pictures and descriptions of how disease occurs and where we should be looking for it and how we should be describing it. There's also some really great free to download articles that have come out of Australia here. One by a sonographer named Jing Feng, which is on how to diagnose endometriosis. That's from the Sonography Journal, and another by Dr. Matthew Leonardi, which is in the AGEM, or the Australasian Journal of Ultrasound and Medicine. And they both sort of detail how to perform the scans in a step-by-step way. So they're both really excellent. There's also some great YouTube channels which have some great videos for all sorts of bits and pieces on it. So I highly recommend Gynecology Ultrasound, which is run by a gynecologist from the UK called Susan Johnson. City Imaging, which is Dr. Sophie Pearson here in Australia. Her YouTube channel has lots of resources. And Dr. Matthew Leonardi is probably the third one I would recommend in terms of a YouTube channel, which has some great resources for scanning for endometriosis on it. So those things are probably a really good starting place. And I think from there, you can really start to pick up some of the basics at least, and really start incorporating, even just basic things like the sliding sign. So that's one of the really big things in the SIU consensus is the inclusion of the sliding sign, so testing the movement of the uterus against the bowel to detect pouch vagus obliteration. If you can scan the uterus, that's a relatively simple maneuver to include, and it doesn't take a lot of time. And then really starting to get to look into the posterior compartment and around the uterosacral ligaments, you really start to diagnose a lot of disease. And then from there, you can progress on to looking through the bowel and through the anterior and posterior compartments.
That's great stuff. I mean, you definitely gave everyone, I think, a really good starting point. There's no excuses with all the information you gave. Well, thank you, Alison, once again for taking the time to share all these insights, and thank you for the work you do.
Thank you for having me. I'm always happy to talk about endometriosis.